Dr. John Bennett, broadcasting from Miami. Tonight we have another in a series of Parkinsonism educational hangouts with Dr. Abdul Rana of Toronto, a neurologist and a world-renowned Parkinsonism educator. Tonight the topic is psychosis and anxiety in Parkinsonism. Good evening, Dr. Rana.
Good evening, Dr. Bennett. How are you doing tonight?
Very good, very good. Okay, let's start things off with a question. How is anxiety related to Parkinsonism?
Anxiety and panic attacks are reported by a significant number of Parkinson's disease patients. They not only report just the anxiety symptom, but they also report many other systemic symptoms. So some of the patients, they get anxious over very subtle things in their daily life. Suppose if they didn't have a bowel movement that day, or if someone calls, a phone call is coming, or if they have visitors, or if they live with the kids and they have any visitor, or if they have to go out, so they would get quite anxious about these things. Sometimes they would read the side effect of a medication in the package insert which the pharmacist gives them, or they go online and look at Google, so they would be just preoccupied with those side effects and would believe that they are going to have all those side effects which are listed there. So these symptoms cause them quite a bit of stress. Other patients may have in addition palpitations, dizziness, or sometimes they may breathe fast subconsciously. That could lead to shortness of breathing, episodic sweating, and some patients may pass out with anxiety and panic. Some of the patients may hyperventilate, and they may have hyperventilation syndrome. With hyperventilation, they may develop the numbness of fingertips or their lips, and this may make them quite anxious. So this is like a vicious cycle. When they get this numbness and tingling in their fingertips and lips, they become more anxious, they breathe fast, and this leads to even more numbness and tingling, and that increases their anxiety. So this may lead to fidgetity and agitation. So these type of episodes may be very frightening to the caregiver, and the caregiver may seem helpless. So agitation sometimes could be caused by some of the medications. Some patients could go into panic. They could have a fear of losing control, fear of falling. They might sometimes think that their spouse may leave them alone. They may lose consciousness. So if these symptoms happen at nighttime, they can lead to insomnia. They may have trouble falling asleep. Sometimes they may have early morning awakenings. At other time, if they go to bed, they cannot fall asleep. They keep on making trips to the washroom. So this leads to even more anxiety. They will go to washroom, come back, and they will get further anxious about things, then make another trip. So this anxiety leads to more nocturia, and this feeling of nocturia even makes them feel more anxious. And some patients may call 911. So these things make them quite stressful. I had a patient. He was elderly. His wife passed away, so he was alone. His son lived just a block away, but because he was alone now, so any noise in the house, any little noise at nighttime, or if there's a wind and he's hearing a creaking in the roof, so he would feel quite anxious, and he would call 911. So the paramedics or police would come every few days. They would reassure him they would not find something, and at times he would feel that someone is hiding in the garage. So these things are not uncommon in patients with Parkinson's. So when you see these patients, if the anxiety is mild, you can reassure them. Slow deep breathing can be helpful. I had a patient who we taught slow deep breathing. So anytime he would get anxiety, he would just lie down, start breathing slow, and hold, and then will let it go slowly. So this used to help him. But sometimes this symptom of anxiety could be quite difficult to treat. We sometimes suggest to the patients that they should not live alone. They should live either with someone or a caregiver, or they should have more counseling. At times we may have to refer these patients to psychiatrists. We might have to use benzodiazepines in these patients, but still they keep on having these episodes. And sometimes the anxiety may start quite before the motor symptoms of Parkinson's disease. So these patients are already seeing a psychiatrist for generalized anxiety, and then they develop symptoms of Parkinson's, and this is how they are referred to a neurologist. And you find out that the anxiety started a while ago before the motor symptoms and the diagnosis of Parkinson's disease.
Dr. Rana, how common is psychosis in Parkinsonism patients?
Psychosis and hallucination is seen in at least 20 to 30% of the patients with Parkinson's disease. If patients have dementia, then the hallucinations, delusions are even more common in these patients. So several figures have been reported. Those patients who have cognitive dysfunction, about 37 to 70% of patients with dementia may have psychosis. They may have visual hallucinations. And if a patient develops a reaction to dopaminergic medication, a psychotic reaction early on in the course of disease, this may be a predictor of later onset of cognitive dysfunction or dementia in these patients. And sometimes these symptoms could be an important cause of the long-term home placement. And these symptoms are more common in elderly patients, especially the drug-induced psychosis. Sometimes the drugs which we use to treat Parkinson's disease, they may lead to psychosis, anxiety, as well as hallucinations. And some patients may have these episodes only in the wearing off periods, when the effect of medication wear off, so they get into this cyclical anxiety, and sometimes they have hallucinations when the medications are working, and sometimes they may have hallucinations when the medications are off. And at times there may be no relation with medications. Dopamine agonists may cause hallucination more often as compared to levodopa. So some of these patients may just perceive a false image, such as if there is a shadow or if there is a curtain in the house, they might, and the curtain starts moving, they might feel that someone is entering in the house. Sometimes they may have the hallucination, but they retain their insight. They may know that these are just false, and they don't get scared. I have a patient. He is a healthy Parkinson patient. I call him a good, strong patient. So he sees ants on the floor of his washroom for several years, but he understands that this is not real. So every time we meet, I tell him that, should we treat you? He said, no, I'm fine with it. I understand this is not real. But other patients may go into paranoid ideation. They may see worms in the food, or they may develop delusions. They might think that their spouse is having an affair. So sometimes these hallucinations could be well detailed. They could be well formed, and they may take the shape of stories. Sometimes patients may tell you stories that people visit me, or my father-in-law visited, or the parents who passed away, or a spouse who passed away. They would see them. I had another patient who would feel that the caregiver who was doing a spray for the insects in the house, every time he would come, he would tell me that this caregiver, his kids hired for him, he used to tell me that he does the spray for the cockroaches on me. So I have to convince them every time that I don't think he's doing a spray on you. He's trying to use the spray to avoid the cockroaches. The auditory hallucinations are much rarer as compared to visual hallucinations, but usually those patients who have auditory hallucinations, they have visual hallucinations before the auditory hallucinations. And hallucinations and psychosis may limit the choice of medications when it comes to treatment of these patients. And some patients may develop these symptoms only in the evenings, especially if they have dementia. So they may have sundowning. So in the evening time, they may get agitated. They start seeing people. I had a patient who would see that every time, at the time of sunset, he would see that the kids come on the doorstep and they ring the bell. So he would go and open the door. He would not find anyone. So other patients could be quite confused. So sometimes they cannot find their own closet, or they cannot find a washroom. I had a patient who was living in his house for 17 years, but sometimes he could not find the washroom. He would go into closet, or he would go into a den they had, and he would think that this is the washroom. So these things do happen in these patients, and if these patients have cognitive dysfunction, this could be indicative that their progression would be a bit rapid than the other patients who don't have hallucinations.
Do you feel comfortable, doctor, treating a patient with psychosis? If you determine that the patient does have psychosis, do you treat the patient, or do you refer them to a psychiatrist?
Usually we treat these patients ourselves, because the treatment for psychosis is quite simple. So in most cases we deal with this ourselves for several reasons. So we are very well familiar with their medications, their overall condition, their course of disease. So we do treat these patients ourselves. However, in some cases you may need help of a psychiatrist. Suppose if they have auditory hallucinations, or if they have very strong delusions, or they need a continuous psychotherapy, so then you can refer them to a psychiatrist. Finding a psychiatrist is not easy all the time.
Okay. Okay. Can drugs play a role in causing psychosis?
Yes, the drug-induced psychosis in patients with Parkinson's disease is a very important factor in causing patients long-term care home placement. Because with drug-induced psychosis, the caregivers feel quite stressed. So if you see these patients and you reduce or simplify their polypharmacy, or if they have a UTI, you treat them, or if they have pneumonia, electrolyte abnormalities. So if we address these things, the hallucinations and psychosis does improve. If a patient is on multiple Parkinson's disease medications, so the first medications to stop would be anticholinergics, or amantadine, and then monoamine B inhibitors, COMT inhibitors, and then dopamine agonists, and then slowly, if patients still have hallucinations, their dose of levodopa could be adjusted or slightly reduced. However, if their psychosis still does not improve, then newer atypical antipsychotics can be used, such as clozapine or quetiapine. So these medications are quite helpful in treating psychosis. Clozapine is a medication with some serious side effects, so it may drop the white cell count. So these patients may have have to do blood tests every few weeks, and usually they are followed in a clozapine program very closely. Otherwise, quetiapine is quite safe, and it does not have any effect on the blood count, and there is no significant motor dysfunction, because whenever the question of antipsychotics comes, the motor impairment is an issue. But with these medications, there are not much motor slowness, and the symptoms improve without causing any worsening of Parkinson's disease patient. Another side effect clozapine can cause is drooling or sedation. Postural hypotension is also possible. Low dose of quetiapine is quite helpful. These patients can be treated with only 12.5 milligram of quetiapine, and their symptoms may improve. Sometimes we may have to go on higher doses, such as 100 milligram of quetiapine or so.
L-DOPA does not cause psychosis, does it?
L-DOPA could cause psychosis, but in the list of drugs with Parkinson's disease, yeah, that would come in the lowest, I would say. Right.
Okay. Okay, very good. Is there anything else to add before we close on this topic?
Yeah, when these patients are seen in a follow-up visit, if they are having hallucinations, so first of all, screening is very important. In the follow-up visits, there should be a permanent question on every follow-up visit about hallucinations and psychosis. And this should not only be asked to the patient, but also to the caregiver or other family members if they are with the patients. And then a few important things, such as making sure their nutrition is adequate, their fluid intake is proper, and repeated orientation sometimes help, like putting a clock in the room, opening the curtains, having their room or apartment with the light, taking the patients out, and telling them the date and time on daily basis, having a calendar in front of their desk or a bed, and improving their nighttime sleep is very good. And if they wake up at nighttime confused, the lights should be turned on, and the caregiver should not try to argue with the patient. If the patient believes that the hallucinations are real, they could explain to them gently, but they should not argue with them, and neither they should reinforce their belief. So also ruling out other precipitating factors such as infection, dehydration, or trouble with their vision or hearing is very important. With respect to the physicians, so they should first look at any of the offending agents. So any of the sedatives or anxiolytics or anticholinergic medications, they should be stopped. If they have UTI or pneumonia, that should be treated. If patients have depression, addressing that would also help. And if they are on multiple anti-Parkinson drugs, as I mentioned before, then they should try to address anticholinergics, amantadine, or monoamine B inhibitors, COMP inhibitors, or dopamine agonists, and then they could lower the dose of levodopa if it comes to that point. And if still it does not help, then they can go to newer antipsychotics, as we were just discussing. And if they have to use sedatives such as benzos, they should use only for a short time. And if patients have cognitive dysfunction and they need to be treated for dementia, then ribostigmine is very helpful, because ribostigmine would not only help the cognitive part, but it would also help the hallucinations.
Okay. Okay. Very good. Okay, I guess that wraps it up for psychosis and anxiety and Parkinsonism. And another series of Parkinsonism educational videos can be seen on Parkinsonism TV. Thank you, Dr. Rana.
Thank you very much.
Good night.
See you tomorrow.